Thank you for the invitation. I thank the organizers, Magnus Conferences for the invitation to present at the Global Conference on Pharmaceutics and Novel Drug Delivery System. It's a pleasure to be here. So the title of my talk is Clinical Decision Making in Advanced and Metastatic Breast Cancer Cases between PARP inhibitors and CDK4/6 inhibitors. And as one of the presenters was talking today about personalized medicine, these two types of drugs are targeted therapies. They target the signaling, the cellular processes of the cells, such as tyrosine kinase pathways, or cell cycle dysregulation, or DNA repair pathways. So in this particular case, PARP inhibitors, they are DNA repair enzymes, and CDK4/6 inhibitors are part of the S checkpoint, S cycle checkpoint in mitosis. So as CDK4/6 inhibitors are active in the cell can undergo mitosis. And now, why is this important? Because cancer cells need to repair their DNA, and they need to undergo mitosis to survive, right? So if those particular processes are inhibited in the cells, then the cancer cells cannot divide, hence they will undergo apoptosis. Now, the particular beauty of this drug is that these targeted agents are that they only target the cancer cell and do not target the normal cells surrounding it. So that's why they're called targeted therapies. And the first targeted therapy that came on the scene was actually called imatinib for the myeloid malignancy, chronic myeloid leukemia, and they target the BCR-ABL chromosome 922 translocation in myeloid cells that are abnormally activating. Abnormally dividing. So the agenda for this talk is first to describe the mechanisms of action for each class of agents, which I alluded to when I described about DNA repair processes and cell signaling, and describe their development and the use of this patient population, which is locally advanced and metastatic breast cancer cases, summarize the clinical data outcomes for both classes of inhibitors, and the particular molecular subtype that these inhibitors work on are the hormone receptive positive, HER2 negative advanced breast cancer patients. And now, why is that important? Because this is a specific molecular subtype that has the most prevalence in this patient population. Now, there are other types of breast cancer molecular subtypes, such as HER2 positive, and triple negative, which is HR negative, progesterone receptor negative, and HER2 negative. And these triple negative breast cancer cases are the ones with the worst prognosis and are usually treated with cancer immunotherapies, which are small molecule. They're usually called biologics. And now, why is that important? Is because CDK4/6 inhibitors and PARP inhibitors are small molecule inhibitors, which distinguishes them from biologics such as Herceptin, which you may have heard of in the literature, which I'm sure you've heard of. And then describe the adverse events associated with each mechanisms of resistance. And then I'm going to, at the end, conclude with what I think makes this presentation unique, in that it would describe a clinical decision algorithm such that for this patient population, which inhibitor to choose, PARP inhibitors or CDK4/6 inhibitors, because when the oncologist is faced with the HR plus HER2 negative patient, and which inhibitor do you give, right? So there's a number of factors that go into it. Now, what's complicating this particular algorithm is that there are so many clinical trials on this particular subject with this question being asked. And in addition to the clinical trials, there's toxicity profiles, there's adverse event profiles, and there's mechanisms of resistance. There's also predispositions such as the BRCA1/2 gene, which is the genomic mutation. So there's a lot of complexity in terms of figuring out what is the most efficacious outcome for these patients. So the background is that PARP inhibitors and CDK4/6 inhibitors have been studied extensively, as I just mentioned, and they are model targeted agents for advanced and metastatic breast cancer cases in this molecular subtype. Both agents have been evaluated extensively in clinical trials. Their efficacy and toxicities are very well known for oncologists, and they communicate this with their patients, right? So the comparison of these agents is presented, and what I try to explain is that PARP inhibitors, they're active, which I'll make clear shortly. They're active against genomic BRCA1/2 mutations, which I'm sure you all have heard of, whereas CDK4/6 inhibitors do not have efficacy in that mutated patient population. So breast cancer is, of course, a very heterogeneous disease. In other words, when you get a tumor, each cancer cell the cancer cells are all different from each other. So the tumor is what is called heterogeneous. So so with the 75% of breast cancer cases have this molecular subtype, and it's very important because they have a relapse rate of about 25% and a median overall survival of about 40 months. So it's a cancer with a relatively poor prognosis, not the poorest like triple negative breast cancer, but it does have a poor prognosis. So as I said before, the factors that contribute to the PARP inhibitor being administered is the presence of the BRCA1 and BRCA2 mutation, which I'll illustrate why shortly. So what is the mechanism of action of PARP inhibitors? Well, it's actually very, very complex because PARP inhibitors, they repair single-stranded DNA breaks. So if you have the PARP inhibitor, it's going to repair them, which is great, right, in the normal cell. But a cancer cell, we don't want that to be happening. So the PARP inhibitor is going to do base excision repair on this cancer cell. So if you give a PARP inhibitor, oh, that would be great. Well, no, that's not enough because of the homologous recombination pathway. Because the homologous recombination pathway is repaired by the BRCA1/2 protein. So if that's mutated, right, the HR deficient cell has synthetic lethality. So in an HR proficient cell with BRCA1 mutation positivity, and without it being mutated, PARP inhibitors won't work. So for synthetic lethality of the PARP inhibitors, you need the DNA single-stranded break pathways to not work, as well as homologous recombination deficiency, which is also called HRD. So the clinical trials. So there's three main PARP inhibitors for breast cancer. And they are olaparib, veliparib, and talazoparib. Olaparib was evaluated in the Olympiad AD trial, and it had an objective response rate of about 60% in the experimental group. Now, PARP inhibitors, unlike CD4/6 inhibitors, they are compared with chemotherapy agents. So the comparator is chemotherapy. So in terms of olaparib in this Olympiad AD trial, Olympia AD trial, the overall response rate was about 60%, which is pretty good. And for the chemotherapy group, it was about 30%. Now, veliparib, I'm sorry, I don't have these numbers memorized. I have to read them off the screen, unfortunately. So in combination with carboplatin and the presence of the GPRA mutation, the median progression-free survival was about 33 months. Overall survival was about 32 months in the Brocade 3 trial. Now, the talazoparib was evaluated in the Embraca trial and had a median progression-free survival of 8.6 months, and a median in comparison with the investigator's choice of chemotherapy of 5.6 months. So in terms of the adverse events that led to treatment discontinuation, olaparib, usually the adverse events are neutropenic. They're hematologic, not malignancies, but hematologic events such as neutropenia, anemia, and leukopenia as well. So those types of hematologic disorders tend to be the side effects of PARP inhibitors. They're also associated with fatigue. So olaparib, you'll see the numbers, the toxicity is 4.9% versus the chemotherapy group of 7.7%, but very little incidences rather of secondary malignancies such as acute myeloid leukemia or a myelodysplastic syndrome. Now, veliparib, there was treatment discontinuation of about 4%. Yeah, 8% rather. Sorry, these numbers are very hard to read. And in the instances of anemia, neutropenia, with non-significant instances of fatigue and thrombocytopenia. So the causes of PARP resistance, there is some element of PARP resistance in breast cancer cases, in breast cancer cells. And most of it is because of restoration of the homologous recombination pathway in cells that are deficient for them. And also prior exposure to chemotherapy. Many of these patients have PARP inhibitors or maybe a second or third line administration. So you have, prior exposure to chemotherapy through this particular type of mechanism of upregulation of drug efflux pumps, they lead to PARP resistance in some cases. So the mechanism of action of CDK4/6 inhibitors may be considered just as complex as PARP inhibitors, because CDK4/6 are two cell cycle proteins that allow the cells to pass the S checkpoint and go into G1 phase of mitosis, which is great for a normal cell, but not for a cancerous cell. And CDK4/6 inhibitors, yes, they are administered with chemotherapy, but they're also administered with hormonal agents such as letrozole and fulvestrant. In these particular patients, when you're administering CDK4/6 inhibitors, it's usually, sometimes or many times, it's in the second line after the non-efficacious administration of the endocrine agents. So going back to the mechanism of action. So yeah, so if the CDK4/6 proteins are there, you lead to phosphorylation of the tumor suppressor retinoblastoma protein, and then that leads to transcription of the E2F transcription factor, and that leads to cell signaling taking place, and the cell is going to be dividing properly, which you don't want in a cancer cell. So in CDK4/6 inhibitors, when they're administered, the cancer cells do not divide and undergo apoptosis. So these are the CDK4/6 inhibitors clinical trials. I will refer you to the paper written there, which has the for the Paloma trials, the major CDK4/6 inhibitors are abemaciclib, palbociclib, and ribociclib. Abemaciclib was evaluated in the Monarch trials. Palbociclib was evaluated in the Paloma trials, and the ribociclib was evaluated in the Mona Lisa trials. So if you refer to that paper, you will find the details about patient population, the number of cohort, the menopause status, and the therapeutic regimen, and progression-free survival and overall survival. Now, I do want to say that the details about these trials, I actually published this presentation in a paper in the Journal of Clinical Case Reports and Clinical Case Reports and Case Studies. It's the July 2024 issue. That paper has a couple of tables on CDK4/6 inhibitors and PARP inhibitors that has information on the trial, what is the type of targeted mutation, the patient population, the agent versus the comparator, primary outcomes, and also the details on progression-free survival, overall survival, and the incidences of adverse events. So all of those details are in that paper in the July 2024 issue that I authored in clinical case reports and case studies. So it's all online. You could just Google my name or not Google my name. It's not going to be on PubMed, but if you Google I'll refer back to that paper in a moment. But common adverse events, of course, are hematologic ones, such as leukopenia, neutropenia, anemia, but there's also incidences of fatigue, diarrhea, and liver malfunction, as seen with these increased ALT and AST instances. So the mechanisms of resistance of CDK4/6 inhibitors are that tumor suppressors such as RB become activated. So if that happens, then cell divides. It does not undergo apoptosis. There's other types of tumor suppressors such as INK4, which when they're activated, the cell undergoes will undergo mitosis and will not apoptose. Also E2F amplification, which is implicated in the mechanism of action of CDK4/6 inhibitors. Once they're able to be amplified rather than expressed, so there's a distinction between those two. Once they're able to be amplified, then the cell will enter mitosis. So what is this clinical decision-making algorithm that I'm proposing, which I think makes this decision-making process between PARP inhibitors and CDK4/6 inhibitors, maybe rather interesting. Well, in that context, there were two clinical trials that were performed in 2023 called the SONIA trial and the Palmyra trial. And what they showed is that with the administration of CDK4/6 inhibitors, there was less overall survival, less median progression-free survival, and a more financial toxicity and more adverse events. So that's a negative study on CDK4/6 inhibitors. So you'll have to take that into account with this algorithm. Now, there's another aspect, abemaciclib, one type of CDK4/6 inhibitor. It actually can cross the blood-brain barrier. So if there's CNS metastases, then this drug is very potent for that. Also, ribociclib has a very, very adverse bad side effect where they lead to QT prolongation, leads to cardiotoxicity. So for patients who have cardiac issues, we don't want to administer ribociclib, and maybe want to go to a different type of CDK4/6 inhibitors, such as palbociclib and abemaciclib. So what do we need to do with this clinical decision-making algorithm? Well, we identify the molecular subtype. Is it HR positive? Is it HR negative? Is it HER2 positive? Is it HER2 negative? Is it both HR positive and HER2 negative? And then perform genomic BRCA testing. That's very important because it's not somatic BRCA1/2 testing, it's genomic BRCA1/2 testing. And why is that important? Because in genomic BRCA1/2 testing, you're testing for the mutation in hereditary cells, whereas in somatic BRCA1/2 testing, you're testing for the mutation in the tumor cell, which is not really that relevant in this case. So we want to take the patient, test the patient for the molecular subtype, determine what that is, and then determine genomic BRCA1/2 testing in hereditary cells. And if it's positive, then you approve the PARP inhibitor. Targeted therapy may be considered. If it's negative, possibly considered a CDK4/6 inhibitor in that setting. Now, I told you about the SONIA and Palmyra trials. I'm sorry, they were 2022, not 2023. Now, so as I was doing reviews, I was studying reviews for these agents. There was one study, a real-world observational study that really stood out, which was the breakout study, which was performed in 2020. And in that particular study, what they found was that if CDK4/6 inhibitors aren't working, that even in that patient population, so post CDK4/6 efficacious administration, we can actually do genomic BRCA1/2 testing for possible PARP1 administration. So even after all the initial testing is done, we can do testing in the clinical setting for the genomic BRCA1/2 mutation. So here I have a slide. So there's also other treatment statuses, treatment strategies after CDK4/6 inhibitor resistance. Maybe give another targeted therapy such as mTOR inhibitor, everolimus, or a PI3K inhibitor such as alpelisib. I'm sorry, some of those drugs are a little bit complicated. Or maybe switch to chemotherapy. Those are all other types of treatment strategies. They're well discussed in the literature. But what is not discussed in the literature is this post clinical setting, no, rather post clinical setting testing of the BRCA1/2 mutation. So you have a positive BRCA1/2 test, a positive genomic BRCA1/2 test. You give olaparib and veliparib or talazoparib with Olympiad AD for olaparib, and Brocade 3 for veliparib, and BRCA for talazoparib. There was also another trial, that the I-SPY2 trial, which talked about a chemotherapy veliparib administration for positive BRCA1/2 genomic testing. Now, if it's negative, we do want to consider CDK4/6 administration either in the first or second line setting, and then what we would do is consider whether the patient was premenopausal or postmenopausal. So that makes a distinction as to which type of therapy to use, which type of CDK4/6 inhibitor to use. And in some of these cases, we do want to do ctDNA monitoring. And then in addition to that, we want to determine that if there is CNS metastases, we do want to consider abemaciclib administration. There's other agents, but abemaciclib has that interesting property. It can cross the blood-brain barrier, so it's definitely one that an oncologist could consider. So we do that, and then the breakout one study was the first study that I found, the real-world observational study that showed that there's about a certain percentage, 4 to 5% of patients who have already received CDK4/6 administration, in a non-efficacious setting or a non-efficacious way, and then do genomic BRCA1/2 testing, and then possibly administer a PARP1 a PARP1 inhibitor. So in conclusion, PARP inhibitor and CDK4/6 inhibitors are considered standard of care for locally advanced breast cancer patients with their associated mechanisms of action, clinical efficacy, safety profile, and mechanisms of resistance. A clinical decision-making algorithm is posited here, which I think the novelty is that we can do a genomic BRCA1/2 testing in the post-clinical setting. And then distinguishing between the PARP1 inhibitor and the CDK4/6 inhibitor. And if, of course, if there's a non-efficacious administration of CDK4/6 inhibitors, consider genomic BRCA1/2 testing, not somatic BRCA1/2 testing, as shown in the breakout trial, which was done in 2020. This trial was published, I believe, in the breast cancer research by O'Shaughnessy et al. In 2020. So thank you. And as I said, let me go back to the paper. I will.